Nolan Kernick, and welcome back to the 5 o'clock news. Our next story this evening comes to you from Macquarie University with our boots on the ground analyst, A.A. Ron, and might I add, best in the biz. He's out there breaking a rapidly developing story on the anatomical and pathophysiological changes in chronic bronchitis. Sounds like a doozy. Take it away, A.A. Ron.
Thank you, Nolan. Jeez, such a handsome fellow that guy is. But I am live here at Macquarie University, and I do want to come to you, the audience, and talk to you about a serious issue plaguing our communities today, and that is chronic bronchitis. And most importantly, I want to talk to you today about the anatomical and pathophysiological changes of chronic bronchitis. But to understand that, we need to know what chronic bronchitis is. And to give it to you short and sweet, chronic bronchitis is a type of chronic obstructive pulmonary disease that's characterized by inflammation in the bronchial tubes, leading to excessive mucus production and a chronic cough. But to dive into more detail, I want to take you guys to my lab, give you guys a bit more information. Come with me. All right, folks, let's break down this airway system. Pretend it's like a major highway. Air comes into your nose, into your trachea, and splits off into two major highways we're going to call your bronchi. From those bronchi, we're going to split into some more smaller roads that we're going to call your bronchioles. And then from those bronchioles, we're going to split into even smaller areas called alveoli. These are microscopic things in our lungs that the site of gas exchange. Oxygen into the blood, CO2 out of the blood, and we keep on living. Now, what chronic bronchitis does is it brings inflammatory markers and obstruction into our bronchi and bronchioles. What that's going to look like is a healthy lung here. Air goes in, easy peasy. I drop my thing. And then from here, this is an obstructed one, mucus inflammation. That takes a long time to come out. Not good for breathing, hence the cough. How this happens is when we're exposed to chronic irritants like cigarette smoke, dust, pollution, air pollution, chemicals, all that crazy stuff. And what this leads to is hypertrophy of our mucus secreting glands, increased goblet cells, which are mucus producing cells, and then thickening of our brachial walls and muscles in the brachii, narrowing that airway, making it hard for us to breathe. Now let's get right into the anatomical and pathophysiological changes. Come with me. Into the anatomical changes that we see here with chronic bronchitis. As we talked about back at the lab earlier, the brachial tubes are important for bringing oxygen into the alveoli for gas exchange. Those there brachial tubes undergo significant change during chronic bronchitis. The inflammation results in the thickening of the brachial walls, thus narrowing the airways and impeding proper airflow. Along with that inflammation, the narrowing is further increased by the exacerbated accumulation of mucus in the brachial walls due to the increased goblet cell hyperplasia and hypertrophy of those cells, which further increases and stimulates the production of mucus. Additionally, chronic inflammation leads to the remodeling and the recharacterization of the brachial walls due to fibrosis and smooth muscle hypertrophy, further increasing that airflow. Now, let's break into the pathophysiological changes of chronic bronchitis. All right, let's further break down those pathophysiological changes and some more anatomical changes due to chronic bronchitis. And these changes have a very complex interplay between environmental exposures, inflammatory mediators, cellular responses. Prolonged exposure to the irritants I mentioned trigger an inflammatory cascade throughout the bronchial tubes. And the inflammatory mediators that I was just talking about are cytokines, chemokines, and protease. And these recruit immune cells such as neutrophils and macrophages towards the site of injury. And these immune cells release reactive oxygen species, proliferative enzymes, leading to tissue damage and extending that inflammatory response inside of our body. And the chronic inflammation disrupts the delicate balance between mucosal defense and tissue repair processes, resulting in persistent inflammation of the airways and constant remodeling of the airways. And then our overactive goblet cells that we've been talking about hinder the function of the cilia inside of our airway tract. These tiny little hair-like structures are meant to clean out our airways and get rid of that mucus. And all these factors together create a vicious cycle inside of our brachial tubes and then the increased mucus plugs up the airway, making it difficult to breathe and traps in irritants and harbors pathogens that can lead to further inflammation and increased risk of infection, which then limits our body's natural healing process and cleaning process, further extending the ill effects of chronic bronchitis. Chronic bronchitis can lead to a lot more complications, such as more respiratory infections and other things such as pulmonary hypertension, and even in some cases, respiratory failure. But I'm no doctor, and I'm not the one to break this kind of news to you guys, but I have a friend that's going to talk to you a bit more a little about it over there. Hey, thank you, Aaron. Dr. D here. As you all can tell, the anatomical and pathophysiological changes to the body during chronic bronchitis are pretty serious things. And patient management and prognosis are very important for us. With chronic bronchitis, we can see a lot of associating symptoms such as chronic cough, sputum production, which is a thick mucus that coats the respiratory tract, as well as dyspnea. With chronic bronchitis, our main objective is to help with lifestyle changes and lifestyle management, such as stopping smoking, as well as pulmonary rehabilitation. For us, this is very much out of our scope of practice, and we should be referring these patients when we recognize symptoms to the proper care. But there was a cool study once done by Marsky, where the article discussed the potential benefits of chiropractic care in managing chronic obstructive pulmonary diseases, which chronic bronchitis does fall under. And the article does explore how spinal adjustments could possibly impact the respiratory function by addressing misalignments that have possibly related to affecting nerve function inside of for breathing. The author suggests that if we fix these alignments, that it could improve the breathing function and potentially alleviate some of the symptoms. But this article does also mention that the treating of COPDs is very much out of the scope of a chiropractor, and we should work together with our medical community and refer patients where they're best to be suited to help get them the best care as possible. So that is pretty much all we can do from our end. I had a great time coming talking to you guys. Aaron, take it away, and maybe I'll see you after work there. Thank you, Dr. D. I'm Aaron, and that's all we got for you tonight. Thank you for tuning in tonight, Sydney, and I'll catch you in the next one. See ya.